terms of medical decision making, this is driven, and table of risk, this is driven by the number of presenting problems. So again, why you want to document and capture everything with the patient and their caregivers of what's going on, the diagnostic procedures ordered, and then your management options considered and selected. Whether things are self-limiting, minimal risk, and few or no diagnostic procedures ordered would tend toward the minimal and low. And then you see the types of management options that are associated with those categories. And then as we move down the left-hand side in terms of the level of risk, and this is probably going to be capturing also more of your patients as well. For the high ones, the one or more chronic illnesses with severe exacerbation, progression, or other side effects of treatment, etc. Acute or chronic illnesses or injuries that may pose a threat to life or bodily function. And at the bottom, an abrupt change in neurological status, which many of you may be seeing in your patients as well. And again, the types and levels of diagnostic procedures or testing ordered, you can see increases in intensity as we go down the chart, and then the types of management options selected, of course, have more significant implications as you move through the chart as well. So again, the buildup of the history, examination, and this medical decision making is going to drive the code selection. Some takeaways on the medical decision making: to document the impressions, tentative diagnosis, confirmed diagnosis, and all your therapeutic options related to each problem. You want to make sure that you've documented each of those related to each of the patient's problems. To not count old diagnosis unless the record clearly demonstrates the presence and your increased work related to that encounter. To document all the tests ordered, reviewed, and independently visualized as part of the work of the encounter. And an observation here is that you see that this is captured the amount of diagnostic services, ancillaries that you have to that you've ordered and you're reviewing and you're documenting, or that are contributing to your medical decision making, is a part of well, certainly part of your documentation, and it's also part of the code selection that results. Do not code based on the number of the presenting problems, but the numbers and risks of the associated with the diagnostic test, as well as the complexity and risk associated with those options. And we saw how those increased as we went down the right-hand side of the chart there. Summarizing old records and outside information and incorporate, and then a concern about templates that overemphasize in this area, and also be aware of the cloning topic that's out there today, and a concern and a concern of the Medicare program. So the build-up on established patients, you need 2 or 3 of these to match. You take the level that was driven by your history, your examination, and your medical decision making, and then here are the 9 codes for established patients. You need 2 or 3 to match to select that code. So, for example, for the 99336 and the 99349, depending on the location of the beneficiary, you could have a detailed history and a detailed examination, but the complexity could be low, or the complexity could be moderate to high, but yet that would still be a 336. On the other hand, if the examination is complete, or comprehensive, but the history is only detailed and the medical decision-making is only moderate, you can't select the 337 or the 350. So 2 or 3 have to match for established patients. And for new patients, 3 of 3 have to match. The level selected for the history, the level selected for the examination, and the level selected for the medical decision making have to match in order to select that code. And again, the 10 codes for the new patients in the home and assisted living facilities are provided here. Just want to mention that there are templates or tools. Certainly, there's probably in your EMRs. There's opportunities and drop downs, and what you've completed is probably producing proposed codes for you to select. But again, you have to do it based on this this basis and code selection. On the two carrier sites, there are templates. One is the NGS, National Government Services, of which for which Dr. Clark is joining us today, has a template tool on their site, and I provide the reference. And also, I've noticed that there's an interactive tool on the First Option site that is also referenced in these slides. So you can get the sense of entering the number of the history, the examination, and medical decision making, and on a live basis, it's showing you the potential codes for selection. Okay, when time can be considered. Time can be considered when counseling and coordination of care is more than 50% of your encounter. This would be face-to-face time with the beneficiary and their caregivers, but it is not non-face-to-face time. That's going to be captured more in the comprehensive, in the chronic care management codes coming online next year. Also, the codes, the time in the codes are provided in the again in the CPT materials manuals, and you can see what the times levels are, and also have a chart here. And then when the counseling or coordination of care is more, but then you have to document the time, and I would recommend start and stop time to select any codes by the CPT codes by the time basis. Prolonged services codes are available, and just wanted to briefly mention those, the 99354 and the 99355. When the amount of time goes 1 hour or more beyond the typical. And just this material will be available for you. I just want to show you how this works. The next slides include definitions and the documentation requirements. Again, this is face-to-face time. And this slide will be available. Again, these materials will be available. There's threshold times. These are the ones that are described as typical for each of the 18 codes. So in terms of selecting a code by counseling and coordination of care, it would be if your encountered need, if that dominated 50% or more for that level code, but you didn't have a reason to select a higher level code based on the history examination and medical decision making. To use the prolonged services codes, this is where it goes an hour or more beyond. The initial 14 minutes of any additional half an hour is not considered. Again, this material will be available for you. You would use these codes in a conjunction with the one of the selected 18 evaluation and management codes for house calls. For the first hour, additional hour, it's the 99354 code, and then each additional half an hour after that, you would add a 99355 to the codes. So you would have the underlying code, a 99354, and then a 99355, and then for each additional half an hour after that would be another 99355. The 99354 is only used once. Mention the contractor tools. Here there's First Coast has the interactive template on their system, and then NGS has a template, and the reference is here as well. Quickly, I want to mention compliance plan requirements. That compliance plans are moving from a voluntary basis as a result of the Affordable Care Act to a mandatory basis when the Secretary of Health and Human Services establishes standards for each area of the Medicare program. Again, they're voluntary now and recommended that you have in place. We will go over this material more in an August webinar, but do want to let you know that the mandatory nature of compliance plans is now, in a sense, enacted, and the specifics of that are yet to be published. In terms of the compliance plan that the OIG has set out as an example for practices, those elements are here, and again, we'll go over more detail in the August webinar. Okay, educational materials are referenced here. The upcoming Academy webinars. Do want to leave time for questions now and reference again the compendium and provide an opportunity for Dr. Clark to provide any. Yeah. Yeah, and Dr. Clark, please, if you want to add some observations to what's been presented here, and please send in your questions now.
Hi, this is Larry Clark. Can you hear me clearly?
Yes. Thanks, Dr. Clark.
Great. I just want to say a couple of things. One of them is that please pay attention to Mr. Schwartz's early slides. The concept of home care is essentially a quality service to a homebound patient. So that sentence, I thought that was very important, where he equates, and the Academy equates what is done in the home to the office visit. If you are managing a patient in the home setting with, advanced cardiovascular disease, then I think it's a reasonable expectation that your home health care practice has a small portable EKG device to do that appropriate management. There may be even more sophisticated things, but this is supposed to be an equivalent service. I do know I've seen some model projects in home health care around our jurisdictions of New York and New England, and also out in Midwestern states. And we do see, pulse oximetry managed well in the home setting, but you have to invest and take the time. This is not an alternative or a poor substitute. This is quality care, and we expect to see that in the records. The other thing in Mr. Schwartz's slides, which I thought was really compelling and something that needs to be reinforced, is the frequency of the visit should match up. I mean, I'm an internist. I still practice part of the time. I see patients with hypertension perhaps every 3 to 4 months. If you're managing a patient at home with stable, well-managed hypertension, I would think that the frequency of the home visit should match up with the general frequency of the office visit. Now, understanding that some of these patients, because of multiple comorbid conditions and frailty, may need more services, you have to let us know. And again, I think Mr. Schwartz's slide was dead on, that these can't be inactive problems. It can't be that the patient had an MI 14 years ago but is doing well. Obviously, that means there's cardiovascular disease, atherosclerotic coronary disease, but nevertheless, it is stable disease because it's being well managed. If, on the other hand, the patient is having dyspnea and anginal symptoms, then there might be need for additional visits. But the record's got to tell us that. And honestly, all Medicare contractors only review a small amount of the claims that come in the door. Really, just in many situations, less than 1% of the total claims. However, I do think that if we are going to look at a home health claim, we're going to look and see that the documentation supports the medical necessity. I think if there's one message that I could express after this, we are looking at the medical necessity. I'll also express one caution, and then I'd like to turn it back to Mr. Schwartz and see if there's questions out there. We are experiencing some problems on prolonged services. And I think, again, there's an overarching principle of medical necessity. If you are going out to a patient's home and there is concern over multiple organ failure and dysfunction, and you're meeting with the family, the next of kin, perhaps changing the status or the intensity of the services, if you're discussing those legalities, if you are writing and developing an additional care plan that's going to be shared with a home health agency that's also coming, yes, it might be. But unfortunately, we're seeing a large uptick in some areas in home health services of a prolonged care nature, and I think we've got to look at that. I mean, it is very hard for me to see. I gave you a circumstance, exactly a family needing a change in the status and aggressiveness of the care of a patient, multiple organ failure, but this is not a routine thing. Prolonged care is not meant to be a routine code. It's meant to be an exceptional code for those times when you legitimately have to spend that extra time to do a good job. And on that, I'm going to turn it back to Mr. Schwartz and see what kind of questions you have. Thank you.
Sure. Thanks, Dr. Clark. And just kind of working backwards, Dr. Clark mentioned some of the documentation changes that may occur based on the patient's status, changes in your discussions, just as with the chronic care management codes that are under development and we expect to see in the proposed rule. We may see later on in the rulemaking process advanced care planning codes and potential coverage and payment for those services distinct from your evaluation and management services, and there's a potential for those to be covered in 2015, but that may, again, we need to see that in the rulemaking process. One question is seeing the patient to see a face-to-face and following the patient who also happens to be on home health services and is indeed homebound. Do we need an order from the primary of record to follow the patient as a consult? And I'd be interested in Dr. Clark's perspective, but and you do want to establish that provider-patient relationship, and it would be good that if you were not the part of the practice with the established relationship, that you do establish that relationship as a primary care provider with the patient. And again, there is no essentially, I may have used the word consult, or that may have been in the language. Consult as codes are gone, but the concept that you've been brought in and have that relationship with the patient be established.
I will totally agree on that. I think that we're looking at a situation of who's doing the work here. And basically, if an office-based community practitioner or a hospitalist says this patient needs home care, first of all, you've got to establish the medical necessity of the fact that the patient is homebound and needs your services delivered in that home setting. And so I think some type of note that indicates a transferal of the primary care management. You're now going to be assuming care plan oversight. You are going to be calling in the medications or updating. You're going to act as the liaison to any other home health, visiting nurse agencies, etc. If the community office-based physician is still doing it, I think we're going to question, what is your role? Where did home health care begin and end, and why is it necessary? So totally agree there. You need to get it into the chart that you're picking up, that you're the captain of the ship now, and that this patient is homebound and you're going to provide that care. Thank you.
Okay, we have a few more questions, just with a few more minutes, so I'm going to go quickly here. A 90-year-old patient with acute exacerbation of chronic disease. They only need low-level diagnosis, chest X-ray, EKG. If coding is based on risk to the patient, threat to life, et cetera, or based on diagnostics, would the coding be low? Again, the coding is driven by the history examination and medical decision making. So, you know, each of those plays a role as part of the you know, the build up or the selection of code. So hopefully that's addressed the question. In terms of
MDM is very important in this one, medical decision making. If you're seeing a patient, they have multiple problems, but you've got a good handle on them, and you're managing them the same way, then your decision making may not be up there. If the person has had a major clinical change, I think one of the areas that's clearly not documented well enough is medical decision making. Thank you.
Okay. The additional time, as long as there's start time and end times in the documentation, I think Dr. Clark covered that. The prolonged services, there has to be that documentation, just like the code selection based on counseling and care coordination. Again, start and stop time, but you know, again, as he described, there'd be the rare situations when it'd be required that you be, again, face-to-face with the patient for that long. Two quick, perhaps two quick questions. The billing timeline for Medicare patients, we can send out that out in terms of, and I know there's been changes over the years. Dr. Clark, I don't know if you have that at top of mind for claim submission.
You mean what our floors are?
Oh, well, for the, not for the payment, but I think, well, actually, I'm not sure if it was payment level or maybe the end date of when you can get a claim in and still be covered.
I think it's a year, right, Gary? I mean, I do think you have to have timely filing. Why would that be a problem?
Yeah, so I'm not sure if there's enough language for the
busy home practice would not be able to get a claim in at least within a quarter of the service.
Okay. One last, Dr. Clark, the topic of travel time, we don't see it as a, you know, as a express covered service. What is, and then use of, you know, ABNs, you know, there's a variety of practice out there. Do you have a perspective on travel time for mobile providers such as in the academy or other, and ABNs?
Okay. Unfortunately, not all of this is well addressed. As you well noted in one of your slides, the home visits are weighted a little bit higher. This is something that is supposed to take in your travel cost, auto overhead, gas, you know, whatever it takes. We recognize that in some situations this is probably more than adequate. In other situations, not at all, not, you know, enough. You might have that exceptional patient that's 40 miles away but really in need and really shut in. They're really, you have what you have, and hopefully your patient mix and growing home services throughout the country, you know, you're not going to be going, you know, long distances on all of your cases. But no, that's kind of you know, supposed to be built in. If you disagree, then obviously that's where your academy comes into lobbying and to representing some of those need issues. But to be honest, the codes are supposed to have that built in. In terms of the ABN, I think your slide also hit that very well, that it is supposed to be a service that is generally recognized and covered by Medicare, but maybe in a specific situation not covered. If you are anticipating providing a preventive service, if there is something that you are doing which is frequently covered by Medicare but is not related to a symptom or a diagnosis active in the patient, doing an extra examination as a, quote, physical examination, doing an examination perhaps to satisfy some legal requirement on top of your regular services, other services in terms of things like routine foot care involving podiatry. An AVN appropriately executed and submitted with the appropriate modifier may help you get paid, but obviously there's also the responsibility to let the beneficiary know up front.
Okay. Well, Dr. Clark, thank you for those insights. That's appreciated, and your participation this afternoon. We want to thank everybody for joining us. If you've submitted some questions, we'll get responses to you after the webinar. Do want to mention again the home care medicine services and compendium of federal regulations that's available, and the promotion that's available to you now as a result of attending this webinar. The next one will be in August on fraud and abuse topics that pertain to the environment in which you practice. And again, I want to thank you for your attendance and participation with the Academy, and then your questions this afternoon. Thank you all.
Thank you.
And have a good afternoon. Thanks, everyone.